This is America, and this is the Department of Health and Human Services, where officials are pursuing a strategy to improve the nation's health. The Trump administration making blockbuster weight loss drugs more affordable, while also urging Americans to rethink what's on their plates. Many wonder if this is the right prescription, or if the national conversation has become too focused on losing weight and not on what it really means to be healthy. More on that in a moment, but first, let's go to our D.C. studio with Alex Marquardt.
Thank you, Eva. Obesity remains one of America's most critical public health crises. According to federal health data, more than 40% of American adults, that's more than 100 million people, and nearly 1 in 5 children are either overweight or obese, which increases the risk of diabetes, heart disease, stroke, and at least 13 different types of cancer. The condition also places a significant financial burden on the healthcare system, with obesity-related medical costs estimated to exceed $170 billion annually. In response, the Trump administration has adopted a dual-track strategy, expanding access to those highly effective weight loss medications through subsidies and price caps, while also championing Health Secretary Robert F. Kennedy Jr.'s Make America Healthy Again initiative. You may have heard of that. It's called MAHA. That initiative promotes whole foods, reduced consumption of ultra-processed foods, and a rethinking of long-standing federal nutrition guidance. As policymakers seek to curb one of the nation's most costly health crises, an important question remains. Is America's path to better health driven by medicine, lifestyle changes, or a combination of both? Eva McKend has this story.
America's fight against obesity is entering a new era.
I take 10 units.
A record number of Americans are turning to blockbuster weight loss drugs. Gallup says 15% of U.S. adults have tried a GLP-1 medication, while 11% are currently taking one. That is a dramatic increase in just a few years. Now, the Trump administration says it is making those drugs more affordable while launching a broader campaign to change how Americans eat.
You will pay the lowest price anywhere in the world.
This is what most Americans innocently put into their bodies these days.
Health Secretary Robert F. Kennedy Jr. says medication alone won't solve America's obesity crisis.
We have decades of good science now that says protein is important. It is absolutely critical.
Just a few years ago, body positivity was having a cultural moment, with artists like Lizzo and shows like Survival of the Fittest challenging traditional beauty standards.
Here's the thing with your plus size line, it's not really plus size.
Hey, ho, ho! Our backpack got no place to go!
But as Americans embrace weight loss medications in record numbers,
we actually don't consider the word obese to be a respectful term.
Tigress Osborne, executive director of the National Association to Advance Fat Acceptance, says another conversation is getting lost.
I've been a plus-size person since I was a teenager. Fat could be a neutral descriptor of a body. It didn't have to be an insult.
The market for weight loss medications is expected to reach tens of billions of dollars in the coming years. Fat-positive advocates say that reality should prompt questions about which approaches to obesity receive the most attention and why.
We always want to be questioning the narrative of the obesity epidemic and the institutions that have forwarded that narrative and what their motivations are. Are they really about health, or are they also about financial gain? There's a lot of money to be made in obesity treatment and obesity research.
Osborne argues making weight loss drugs more affordable should remain a personal choice, but worries it reinforces the idea that every larger body needs fixing.
Creating more access to drugs for weight loss furthers the narrative that everybody can and will and should be losing weight on these drugs. A successful policy would be a weight-neutral healthcare policy, something that looks at people's actual health profiles, regardless of their current body size, and works with patients to set healthcare goals for themselves that are achievable and reliable and are not dependent on shrinking their bodies.
Eva McKend, Al Jazeera, Washington.
And joining me now to discuss this is Joanne Kenen. She is a journalist in residence at Johns Hopkins Bloomberg School of Public Health, and Michael Kenen, who is the director of health policy studies at the Cato Institute. Joanne, Michael, thank you both so much for joining us today. Joanne, I want to start with you. According to Gallup, the share of adults who are considered obese has dropped around 3.5% since 2022. Of course, that coincides with this spike in uses of GLP-1 drugs. So, in short, has America found a pharmaceutical solution to obesity?
We have at least found a partial solution. These are new drugs, and I personally was a little worried about the widespread uptake because I know that sometimes, when clinical trials have X numbers of people and then you go into the real world and X times, a lot more use it. And I'm not a scientist, I'm a writer who, writes about public health. And I'm less worried now. I mean, I think that lots and lots and lots and lots of people are taking it, and the obesity rate has dropped. I don't think it's the fix to all of our problems, but I think that this is really helping a lot of people. One
of the things you have written about is essentially kind of defining success as seeing whether Americans live longer with fewer chronic diseases. So essentially, are you saying the jury is still out? I think on any drug that's only a few years old, there's going to be more to learn. So maybe we have two juries. Maybe we have a jury of is this a good thing for a lot of people now? Yes. Do we have to watch this drug the way we need to watch pretty much any new drug? But people are going to be taking these. Many people will take these for many, many years. So do scientists have to keep tabs? Yes. But every day there's another article and another study that it does more good things than we realized it would do. It seems to be helping for. It's been described as a brain drug, not necessarily a fat drug. That it seems to have a lot of unanticipated good side effects. A precipitous drop like this in terms of the number of obese people in this country, Michael, is unprecedented. How much credit do you think these drugs deserve?
Probably a large measure, because they really do appear to be wonderful miracle drugs. People didn't realize all the benefits were going to be there. And I share the concern and the skepticism about long-term effects. We don't know. I mean, we were just talking about off camera the example of Vioxx, which was a drug that passed the FDA's approval process. But then once millions of people started taking it, data started coming in about side effects, like heart attacks, fatal heart attacks, and so that the manufacturer ultimately pulled that drug from the market. We have to keep that in mind when we're talking about miracle drugs like this, that there could be downsides along the way that we discover along the road. But when you have such dramatic reductions in body mass index, like 20%, after just a couple of months use of this drug, and when you see the cardiovascular health improvements and maybe a reduction in neurodegenerative diseases and other improvements in recovery from addiction, for example. You see all of these benefits, and even if there are some side effects that come with long-term use, first of all, I think we have to credit these drugs with at least a large measure of the reduction in obesity, and even though we're clear-eyed about what might come in the future, we have to, I think, leave the choice to people to make the decision for themselves as those data come in about whether these drugs, it's a whole class of drugs, is right for them.
Right, and I just want to clarify,
Please.
I think we want to study. I mean, a lot of people, millions of people are taking these drugs. Yeah. And they're new, and they're going to be on them for a long time. So I think we have to watch them and study. But I'm not saying I'm skeptical. I'm surprised I was more skeptical when I first heard about them, because we've all heard, quote, miracle drugs, and that turn out to be not so miraculous. This, every week we learn something else good about this drug, that there's so much research and it may help people with issues beyond the ones we already know about.
I mean, this is a ripe market for these drugs. The U.S. is...
chubby.
Your word, not mine. But, the statistics show that it is the most obese developed large country in the world. How did we get here, Joanne?
Well, we have pretty sedentary lives. Many of us sit all day. We do not eat well. I mean, I'm a mom. I struggle with this. I mean, kids are grown now, but, you try. There's so much quick hit, satisfying sugar fat hits out there. It is hard to eat. We're surrounded by fast food. We're busy. It's hard to cook. I mean, cooking is time-consuming. Cooking healthy meals where you have to chop a lot of vegetables is time-consuming.
But all of this is true in other countries as well.
I think that the prevalence of fast food is, I mean, I've not been to every country in the world, but I think and yes, there's fast food elsewhere, but the prevalence of it here and sort of the cultural acceptability and how much we eat without really even thinking about it, I think it's pretty extreme here. It's convenient and it tastes good, some of it.
It certainly does. Michael?
An important perspective to keep in mind is that this is sort of a wonderful problem to have. Because for most of human history, we were struggling not with obesity and an overabundance of food, but with a scarcity of food and getting in enough calories to keep people alive. And we've driven down the price of food so much, and productivity and incomes in the United States have risen so much that the opportunity that it's cheaper to buy food, often fast food, the opportunity costs of making the food yourself are much higher. And so we have shifted our consumption patterns, and there are other factors that I think are going into more sedentary lifestyles and the prevalence of obesity in the United States. But again, it's a wonderful problem to have. And when those problems emerge, as is often the case, technologies emerge to help us deal with those problems. And GLP-1s are the latest example, but there are lots of other things that medicine has developed to help us deal with sedentary lifestyles and the health effects of not exercising enough and not eating right. Statins are an example. All sorts of cardiac procedures and treatments are other examples that people could take care of or reduce their risk of cardiovascular disease if they change their lifestyle, but they choose not to, and then we have these treatments for them. And I think that that we shouldn't be consistent with one of the women was saying on the program earlier. We shouldn't be shaming people for these decisions. We shouldn't be taking choices away from them. We should let them make those decisions if they want and bear the cost of those decisions. I don't agree with Robert F. Kennedy Jr. on much, but he really struck a nerve when he said that maybe the federal government should not be forcing people to pay the cost of other people's obesity treatment. And so if people make those choices, they should bear the cost themselves. They'll make those choices less often. But for those that do, technologies like these will come along and help reduce the burden of those costs or those behaviors so that people can live the sorts of lives that they want to live.
I want to drill down into what exactly these GLP-1 class of drugs do. They've been on the market for some 20 years as treatment for diabetes, but only recently have regulators approved them to help people lose weight. GLP-1 type drugs are designed to mimic a naturally occurring hormone that is found in the small intestine. That hormone makes you feel full. Taking a GLP-1 essentially tricks your brain into feeling full. It lowers the cravings for food. And patients can, of course, lose weight by just eating less. In addition to weight loss, GLP-1 drugs have also shown to help with high blood pressure, with heart disease, and even quitting smoking cigarettes. But there are side effects as well, as we were just mentioning: upset stomach, headaches, as well as more rare and serious conditions such as irritation of the pancreas. So, Joanne, Michael was just kind of touching on it, but if these drugs are not combined with better nutrition, more exercise, does that mean essentially the country or people who are taking these are getting skinnier without getting proportionally healthier?
I mean, it's going to be both, because some people are going to feel, I happen to know, and without naming and shaming anyone in my own social circle, I do know people who are taking GLPs who are not exercising or eating better, right? Are they still healthier? Yes, because they've lost weight, their blood sugar is better, et cetera. I also know people who have lost weight and have gotten more energized and are doing more exercise and are feeling, like I can do this, or like they're not as embarrassed about their bodies. They'll be more willing to go to a gym. So I'm not aware of research showing how many people, it may exist, but I have not seen a study showing, how many people are getting more exercises versus how many people are remaining sedentary. I think it probably cuts both ways. And there are people who have. It's not just diabetes, as we've mentioned. I mean, there's something called fatty liver disease, which is spreading for some of the same. Sometimes it's genetic, and sometimes there are these lifestyle issues. No one realized it was going to also. It was a very hard disease to treat, and a chronic disease, and not all that well understood. And it's helping with fatty liver disease. And it's not that the liver, it's a misleading name. It's not, your liver isn't fatty, but whatever. It's called fatty liver. Some scientists named it fatty liver disease, and that's what it's called. There's a scientific name that I can't remember. But so it's helping many of our organs and our blood pressure and our, Michael and I were joking, like when things, like neither one of us are on it, right? We both eat pretty well. We both exercise. Neither of us, as far as I know, has a serious chronic disease. But like we were half kidding before we came on, but will there be a point where this is such a good drug that everybody should be on it? Like even if you're not in the initial target, I wouldn't say that we should put it in our water, but is it going to help so many things that as it comes out in pill form, as the cost goes down over the years, as there's generics? I don't mean tomorrow. We need to know a lot. I'm not saying that we should all be taking it now. Will there be a time in the future where that's conceivable? Maybe, just like a lot of people take statins now.
But when you stop taking them, the weight essentially comes back. So, Michael, are we essentially getting people hooked on this? Are they supposed to take these for the rest of their lives? Every
Weight loss strategy you have to do for the rest of your life, whether it's bariatric surgery or if it's just eating less and exercising without drugs, whatever it is, you have to do it for the rest of your life. So that's not really a concern. And it's not hooking people on these drugs. If they want to get off of these drugs, they can and live their life a different way, they can get off of them. But what we should be doing here is making these drugs more widely available for people, because they do appear to have so many benefits, but not by having the government subsidize it. Both Presidents Biden and Trump have talked about having Medicare pay for these drugs. Medicare doesn't need to cover Ozempic. Medicare needs to take Ozempic. What we need to be doing to get these, to make these medicines more widely available is eliminating the government regulations that require people to get prescriptions before they access them. Mm-hmm. Those regulations, they increase the cost because you have to go to the doctor, but they also result in more and broader insurance coverage, which insulates the patient from the cost. And so the drug companies can jack up the price, charge $1,000 for a treatment that costs 90 cents to make a month's worth of. And we end up overpaying. But if you move it to if you eliminate those regulations, then some of these drugs will move to over-the-counter status, and people will be paying for it out of their own pocket. And that's when you get the price competition that drives the prices of these drugs down to marginal cost, or 90 cents per month, and that will bring these drugs within the reach of people, and so they won't need government subsidies to access them.
We wanted to find out how people actually think about these GLP-1 drugs, and how they perceive them can actually, of course, depend on how they're being used, as you were just saying. Matthew Torres spoke with several people about how they use them today and how much they cost.
Exercising and eating healthy, that's always been the classic equation when it comes to staying fit. But as more people take the less traditional approach when it comes to achieving whatever their goals may be, people's thoughts on these prescription weight loss drugs can vary.
So I got together with a lot of friends and I was like, how did you lose so much weight? And I watch my weight pretty carefully. I work out a lot. That's part of my lifestyle habit. And first I found myself a little resentful, like how come you just lost weight like that? And I, work at it, and I watch what I eat, and I go to bed at 8:30, and I try to do this lifestyle. But then I realized that some people it just was hard for them to lose weight, and there's all sorts of biological reasons.
I probably should, but I'm going to wait until lots of people have used them and years have gone by.
Yes, I did. I looked into it. I like the fact that you have to get some tests and stuff done to make sure that everything in your health is okay before they actually give it to you. But I didn't move through with the process.
Because?
Just wasn't for me. Just wasn't for me. I feel like naturally, like working out, running, healthy routine, eating healthy, stuff like that, that will help you keep the weight off.
I think that's great for them. And then I do think, unfortunately, there's people who maybe don't necessarily need it and then they're taking it.
If the drug's if they're doing what they're saying they're supposed to be doing, and insurance companies are willing to cover those, and I don't see if there's anything wrong with that.
Oh, insurance companies for sure should definitely pitch in for that, for those who need it. For those who need it.
It's definitely pricey. I feel like I don't know why they're charging us. I feel like it should be like a trial, to see if you understand how it does first before actually paying for it.
Insurance coverage for GLP-1 branded drugs can be spotty, leading to an uptick in what's called compounded versions, sold online at a much lower cost. They are not FDA approved, but according to a Gallup survey, 20% of its users had purchased a compounded medication before. Matthew Torres, Al Jazeera, Washington.
I do want to talk about those compounded versions in just a second. Joanne, let's pick up where Michael left off. What needs to be done to make sure that these drugs are more affordable, more readily available?
Well, Michael has a, ideological difference than
we have ideological differences.
Michael and I get along very well, as you could probably tell, but we don't agree on a lot of things. I do not believe that Medicare should not cover these drugs. Right now, we have Medicare. In a different world, maybe that he envisions, maybe we wouldn't have Medicare in the form we have it now, but we know this drug is helping people, we know it's expensive, and we know that treating diabetes and the complications of diabetes, which can be very severe, amputations and lots of bad stuff, to use the correct clinical term, right? That's expensive. Keeping people healthy is a goal. So would I like to see the costs come down? Yes, I would like to see the costs come down. I'd rather have there are more coming on the market. There's another generation. I don't know how fast it'll come on the market, but there's something else there's several things in development. There may be other kinds of drugs that aren't exactly like GLP-1s, but that are sort of in the same family. So I think we'll see more of these kinds of drugs fairly quickly, so greater competition. I'm not sure whether they're moving it to, there's going to be pills instead of the needles. I don't know how much that'll bring the price down, because some of it is the packaging and the needles and the shipping it, and the freezing and keeping it refrigerated and things like that. So I would like to see the costs come down, but until we figure out how to do that, I want people to have access to it.
And those compounded versions, essentially those have not been reviewed by the FDA. About 20% of users of these GLP-1 drugs are buying compounded versions. Michael, what does that say that people are doing that they're taking that risk?
It says that these medicines are tremendously beneficial. And the supply has not kept up with the demand, or at least the supply channel is coming from the manufacturers. And so we have this wonderful innovation of compounding pharmacies that meet that demand and are providing this very valuable product to people who want it. Are there safety concerns? Of course, there are safety concerns. But the real question here is, what are the net costs and benefits of what some people want to do, which is prevent the compounding pharmacies from offering these medications at all, or have the FDA restrict how often, in what circumstances they can provide these medications. When you do that, you might stop, it's like all FDA regulation, you might stop some harms from happening from unsafe practices, compounding or whatever, or unsafe drugs in the case of the FDA more broadly. But that comes at the cost of denying access to beneficial medicines to a much larger number of people, so that the amount of, so you end up doing more net harm than good. And so I think the FDA should just leave the compounding pharmacies alone. If they harm someone, the victims of those unsafe compounded drugs should be able to take those pharmacies to court, and that ends up doing a much better job of disciplining actors than I think than the FDA or prospective regulation does. But for the moment, what the posture the FDA should be taking is just to leave those compounding pharmacies.
How much are these drugs actually helping the overall healthcare system if essentially people are getting treated on the front end for some of these conditions that later on would cost a lot to treat, but now they might not have to?
Well, I think that's one of the rationales for Medicare starting to cover it, which just began quite recently for weight loss.
Which I have at just $50 a month for people over 65, and that could expire. Is that right?
I mean, Congress is, when the government starts allowing something to happen, like $50 a month drugs that normally would cost more, could it expire? Yes, but once people like things and get used to having them, the government is, I mean, we have seen the government take benefits away. We've seen it in the last year. But in general, voters don't like that very much. So once we start getting something, we tend to like it. I think that we don't know for sure there's always a problem with prevention, right? Prevention happens years down the road, right? If I do something healthy as a 15-year-old, the benefits are going to be years later, and it's hard to attribute those costs. It's hard to calculate them, and it's hard to figure out who's saving the money. the GLPs too. I mean, there are young people taking them. So, will it save money? I think it will. Do we have enough years of experience to know that? Dropping the obesity rate in this, it's diabetes, it's heart disease, it's stroke, it's all sorts of things. So there's increasing evidence. We don't really know yet, but there's very promising data about addiction, alcoholism. That would be great, right? People who haven't been able to, who other addiction treatments haven't worked for, maybe this will do that. There's some evidence. Again, it's early, it's new.
Right.
Maybe dementia. So are all these things going to turn as we study them more? We don't know yet. But the potential is really quite extraordinary.
We only have about 45 seconds left, Michael. You were begrudgingly giving RFK Jr. a little bit of credit, putting aside the vaccine stuff and what we're seeing in measles. What he's doing within the MAHA movement of nutrition and what people should be eating, is there some credit due there?
So if Congress did what he suggested in that one comment I cited him as making, that the government should not be forcing Peter to pay for the obesity treatments for Paul, then that would be a positive step. That would require repealing or changing some of the Obamacare regulations that tell insurance companies you cannot charge people more if their body mass index is above a certain threshold.
It is a fascinating moment in science and health, and thank you both for joining me to explain all this. Joanne Kenen and Michael Kenen. Appreciate it.
Thank you.
And that'll do it from me and the team here in Washington, handing it back to Eva McKend and Al Jazeera's global headquarters in Doha. Thanks so much for joining us.
That's it for this edition of This is America. You can watch us each weekday at 18:30 GMT, or if you're here in the United States, that's 2:30 p.m. Bye for now.